now we're going to go to our keynote speaker. Dr. Phil Ellison will be talking about early protected weight bearing for acute ruptures of the Achilles tendon, and do commonly used orthoses produce the required equinus. So without further ado, Phil, it's all yours. And while you're queuing up, I do want to thank OPED Medical, who is the sponsor for this keynote address.
Thanks, Selene. That's great. Thank you very much. Yeah, thanks for the invite to come and speak on this quite unique event. We'll go through my study that I undertook in 2016 and the research paper that was published shortly after. I undertook this whilst working as a lower limb extended scope practitioner, which in the UK basically means a specialist physiotherapist with an interest in lower limb pathology. So the hospital I worked in is at Aintree, which is probably most famous for the race course and the Grand National race that takes place every April. As you can see from the map, that from those that are not too familiar, Aintree lies in Liverpool, just to the north of Wales, there on the northwest side of the UK. Generally a nice place to work, not as sunny as the photographs tend to show there, but certainly a nice environment to work in. So as I've said, my background was as a lower limb extended scope physiotherapist, and most of my weekly schedule over the last 10 years or so has been working within orthopedic clinics, and particularly within the foot and ankle specialty. During that time, I looked to develop some autonomous clinics and add value to the physiotherapy and the orthopedic department. I worked closely with foot and ankle surgeons throughout the majority of the week. I initially set up a specialist heel pain clinic to take a lot of the difficult to manage tendinopathic patients. The majority of this clinic was involved with patients with plantar fasciopathy and Achilles tendinopathy. Quite chronic conditions in the main. However, we did use this service as the gathering point for TA ruptures. Originally, and before my introduction to the post, TA ruptures would attend the hospital via the accident and emergency department, and they would then come through to a general orthopedic trauma clinic. However, with the introduction of my clinic, it was possible to bring them into one specialized clinic. Originally, this was acute and chronic ruptures of the Achilles. I would say on average, there were about 50 cases per year. And sorry, 1 second. And with the increase in numbers and experience, sorry, I'm just going to, just got a cough.
Hey, Phil. Just
sorry about that.
Hope you're okay. Yeah.
With,
no worries. I hope you're okay.
Yeah, sorry. It's just so yeah. So
quick
with
question.
increased
Just make sure you're
came
hitting the next button on the bottom of the slides to advance it.
Yeah.
Because I don't think things are advancing. There you go.
Okay. Okay. So sorry. Yeah. About 50 cases per annum. With these increased numbers, I would be seeing the patients quite often, right from the initial onset right through to the end of the rehabilitation. And with that increased experience came a lot of extra questions. When we started to look into the literature, a lot of the questions remained unanswered. I have to say that in Aintree hospitals, there was already a culture of non-operative management as a treatment plan for acute ruptures of the Achilles tendon. But although we were in agreement, my gut feeling, having seen many more of these patients and seen them right through to the end of the treatment, was that we could be doing better. although there was generally a low re-rupture rate, I would probably only see 1, maybe 2 re-ruptures in a year or a couple of years. It wasn't immediately apparent that there were a lot of difficulties managing these patients from the complication rate. But rehabilitation seemed really slow. It was very difficult to progress these patients week on week. It was very difficult to achieve a pre-morbid activity level, particularly for these weekend warriors who would perhaps be playing football or soccer, and perhaps the ladies with netball and team sports being very popular in the UK. Generally speaking, the outcome measures showed that the patients weren't particularly satisfied at the end of treatment. Obviously, they are quite a demanding group who want to remain active and return to sports and manual occupations as well. So when we look through the literature, there wasn't much written about the use of the orthoses in the early management of Achilles tendon ruptures. And when we looked into this with more detail, often in the studies, the orthosis wasn't particularly described well. The use of the wedges and how treatment was progressed wasn't particularly well described prior to 2016. And so we decided just to conduct a very simple small-scale study ourselves. And this was largely prompted at the end of the day by myself trying a couple of the boots and walking around in them for a day, as you often do, and just realizing that something didn't quite seem right. Something wasn't perhaps working as it should. And maybe the foot wasn't positioned as optimally as we would perhaps think intuitively that it was. So this study was undertaken in 2016 and published in the Journal of Foot and Ankle Surgery in 2017. And that's what we're going to talk about in the majority of the talk today. So the terms, really, just so that we're all in agreement with some of the terms that I'm using today. Acute ruptures of the Achilles tendons largely include those ruptures that present to the hospital within 14 days, although I think this timescale is a little long myself, but certainly that's the timescale that we utilize for these patients in this study. As far as functional rehab is concerned, we're talking about a period of very limited immobilization. This could be in the boots from day one. It might be in a plaster cast, an equinus cast, that could be weight bearing or non-weight bearing, but we keep this immobilization period to an absolute minimum. Protected weight bearing then ensues, again, normally using some form of orthosis with device to position the foot into an equinus position. And then, incredibly important is this progressive loading of the tendon and the calf complex. So terminology in the study, we referred to a fixed angle boot, which has wedges inserted as an FAWW, or fixed angle walker with wedges. And we referred to the vacoped boot as a vacuum equinus brace. So that's the terminology that will be used. So we started the study by saying that advances in functional rehab have resulted in greater acceptance of non-surgical management of TA ruptures. So there was, in 2016, there was growing evidence that the main outcome measures were very similar across both surgically and non-surgically managed acute TA ruptures if a functional rehab strategy was in place. The major outcome measure that was often mentioned was the absence of the complication re-rupture. And a systematic review, it was conducted just before my study, which showed that there was no difference in re-rupture rate between surgical and non-surgically managed TA ruptures if the functional treatment regime was appropriate. And generally in the studies, 1 to 2% appears quite common. But there's a second complication, that of lengthening, which is often insidious and difficult to see and difficult to appreciate, particularly if you don't manage the patient right up until the point of return to sports and other high demand activity. If the tendon heals in an inappropriate length, as in it's lengthened from its original position, then we're likely to have reduced muscular capacity and function ongoing from that point onwards, irrespective of what functional rehabilitation takes place. We now know since this that it's unlikely that the spiral structure of the Achilles ever returns after healing. And so we may have to accept some form of lengthening, and it is shown in some research that up to 10 millimeters, or about 1 centimeter, is perhaps tolerable with the calf complex able to structure itself to accommodate this. So we concluded the introduction by saying we really need to look at the success of rupture management that's based on not only the absence of complications, but on the restoration of function. Obviously, this reflects my role as a physio, seeing patients not wholly happy in their return at 12 months. It cannot therefore be concluded that the absence of re-rupture ensures effective management has been achieved, as it provides no information regarding restoration of function. So we really need to be looking at using patient satisfaction or PROM scores, as well as functional outcome measures such as strength, power and endurance tests. There's simple heel rise testing. Also looking at calf muscle girth. There does seem to be some research showing that just simply measuring the calf bulk links quite well to validated questionnaires such as the ATRS score. So obviously, if we don't operate and we choose to go down a functional management plan, we're relying upon appropriate positioning of the healing tendon within the orthosis or the cast in the early days, while the hematoma forms and the tendon begins to unite. If we obviously think about surgery, one of the major benefits is the ability to visualize the rupture gap and bring it together and debride the tendon to good quality tendon, which we can't do with conservative management. But the good news is that there is research out there showing that both in cadaveric cadaveric studies and ultrasonography of patients, that a position of maximal equinus, about 60 degrees of equinus, brings the tendons together quite well, very regularly in all cases. But what we do need to consider is that when we look at the foot and ankle complex and we look at this position of equinus, our eyeball will generally look at the overall position of the foot and ankle. So we'll be relating the tibia perhaps to the fifth metatarsal, and that's taking into account all of the joints of the ankle and the midfoot particularly. And so we just need to remember that for the healing Achilles tendon, we're really looking at the appropriate position of the ankle and maybe the subtalar joint. However, only about 60 degrees of that sagittal arc of movement is related to the ankle, with the other 40% coming from the combined movements of the subtalar, talonavicular, navicular cuneiform and tarsometatarsal joints. And therefore we need to be ensuring that we're bringing the hind foot and ankle into sufficient equinus and not necessarily the overall foot and ankle. Again, prior to my study, this has moved on quite considerably since 2015 and Anne-Marie Hutchinson's work with the Vacaped boots. But prior to my work in 2016, these are some of the most prominent papers at the time, and their description of the walker boot and wedges or heel lifts is quite vague. It was difficult to tell exactly what had been used, with the most prominent boot at that time being the Aircast walker. So we looked to ascertain whether two commonly prescribed walking orthoses achieved a satisfactory ankle equinus position. On the left-hand side, you can see our typical standard black fixed angle walker boot with an example of one of the wedge systems that we used. And on the right-hand side, the vacuum equinus brace or Vacaped boot. So we took 10 patients attending for treatment over the next number of months. One patient unfortunately had bilateral ruptures, and so the study included 11 tendons in 10 patients. Commonly, ultrasound is not performed as the diagnosis can usually be made via subjective history and objective examination in most cases, although we would refer for ultrasound if there was any complicating factors or doubt over the diagnosis. Standard management plan at that time was 2 weeks weight bearing and a non-weight bearing, equinus cast, maximal equinus cast, followed by 10 weeks in the functional orthosis, and physiotherapy would usually begin about week 4. So the patients were provided either with the black boot with wedges or the Vacaped boot. We then sought to obtain some lateral radiographs, both in the cast within the first 2 weeks and then within the orthosis. And the measurements that we undertook were to relate the tibia to the talus, so that's the tibio-talar angle, and the tibia to the first metatarsal or the tibio-first metatarsal angle. So this would give us both an equinus angle for the talocrural joint ankle, which is going to relate directly to the tension in the healing Achilles tendon, and also the overall plantar flexed or equinus position of the foot by looking at the tibia in relation to the first metatarsal. We used our Carestream PAC system, which is our hospital X-ray recording system, and then did the statistical analysis on that. So I'll present the results in a couple of different formats. The first format is the table here. What I haven't said is we also then look back at 10 radiographs of a so-called control group. These were obviously not typically an asymptomatic control group, as they had already attended the foot and ankle clinic and had radiographs undertaken. They were probably, they were mostly patients presenting with forefoot pathology for whom we had the appropriate X-rays. So when we're looking at these angles, we can see that in that group of patients, the average tibio-talar angle was 25 degrees and the average tibio first metatarsal angle 24 degrees. Now, when we place the patients into the equinus cast, we can see a quite considerable difference from that control group. We've now achieved 56 degrees so-called ankle equinus and 74 degrees when we then add in the composite movements through the midfoot joints. Now, with the boot with wedges, we can see that that's much lower, and we'll explain why a little later. But the ankle angle or the tibio-talar angle is 28 degrees, which was not significantly different from the control group. While there was some more plantar flexion achieved through the midfoot joints at 37 degrees, but obviously still only about 50% of the values achieved in the equinus cast. When we looked at the same figures for the vacoped boot, we can see a significant increase in the tibio-talar angle at 48 degrees, obviously not quite as much as the cast, and a tibio first metatarsal angle of 54 degrees. Again, significant difference at that one as well. What we can see there, however, is that there's very little difference between the tibio-talar angle and the tibio first metatarsal angle in the vacoped boot, which shows that we're hopefully creating some stability through the midfoot joints and actually achieving the equinus at the ankle and hindfoot and not through the midfoot. So here's a couple of images which I think highlights the issue and the problem quite succinctly. Here we've taken the lateral radiograph with the boot with wedges. The blue lines represent the top angle or the felt that's on top of the wedges, and the blue lines beneath show the position of the 3 wedges. Red line obviously longitudinally through the tibia and through the talus and first metatarsal, and even without seeing the actual values to these angles, you can see that the talus isn't particularly plantar flexed. It's in quite a neutral position there, and the first metatarsal, however, is quite plantar flexed with a divergence from the talar angle. So we can see that there's definitely some movement from the mid-tarsal joints. Now, obviously, we can see on this and appreciate how the flattened top wedge is supporting under the heel, which again is probably for reasons related to comfort in the boot and the shear stresses that would come if the foot were to continually slide forwards in the boot. However, by doing so, by supporting the heel and the hindfoot, we're not really achieving significant equinus through the ankle. In contrast, the vacoped boot here shows the same alignment from tibia to talus, which is now much more plantar flexed. And then we can see that the lines through the talus and the first metatarsal are almost parallel. So there's very little movement from the midfoot joints. Obviously here we can see that the whole boot is plantar flexed. You can just about make out on the back, the posterior side of the boot, the closure and sort of toggle system where there's a key can be inserted to allow to guide pins to be moved up and down and allow the ankle and foot to be placed in the appropriate position of equinus whilst wearing the boot. And this can be dynamized, which is another significant feature of the boot. In graphical format, again, from left to right, we can see the control group, blue representing the tibio-talar angle and green, the first metatarsal angle. We can see there with the foot and ankle walker with wedges, how there's very little difference between the blue boxes showing that there's not really been much change in the ankle angle. However, there is a considerable movement there from the green boxes, with the midfoot being more plantar flexed in the wedges than in the control group. The external equinus boot is not producing quite as much movement at the ankle as the cast does, but it was only about 6 or 8 degrees. Can't remember what I just showed you. However, what the cast does when it's applied maximally is to produce a lot more movement through the combined midfoot joints, and this obviously can relate to some of the complications seen with maximal equinus casts to do with dorsal pressure on the foot and paresthesia relating to the cutaneous nerves on the top of the foot. So we concluded that ankle equinus was significantly greater in the vacuum equinus brace, and that was at about 20 degrees in real money. The use of wedges did produce an overall equinus appearance of the foot that was less than the vacuum equinus brace, and achieved through the midfoot. Satisfactory equinus at the ankle is not achieved with wedges, as the design necessitates that the heel pad rests on the top wedge. So obviously we sought to express caution in the readers. It may be that the fixed angle walker with wedges does not produce sufficient ankle equinus to shorten the Achilles tendon during its healing phase, particularly when surgery is not employed. And that is likely, therefore, to result in tendon elongation and therefore reduce plantar flexion power. Obviously, the main outcome from this is that patients are not happy with their treatment further down the line. They have lower reported outcomes and function and aren't able to return to their previous levels of activity. Now, obviously, there are various wedge systems that are available. These photographs show 3 of the commonly used ones at Aintree, and we investigated and trialed all of these at various points. But I've highlighted some of the major problems that we came across. Firstly, comfort. Often the felt on the top wedge is not sufficient, or there's none in place at all. So comfort from the boot is not paramount, and often the patient would experience pressure on the plantar heel pad, which would result in pain or paresthesia. The wedges, generally speaking, are not made to be solely compatible with a specific boot, and so there's often some fitting issues, or sometimes the wedges can slide around in the base of the boot as well, and that can be quite difficult to manage. The method of joining the wedges together tends to be either a click system, a little bit like Lego blocks, which they are in the top left set of wedges, or simple sort of double-sided sticky tape. And we have had numerous cases where 1 or 2 wedges slide forward on the base wedges due to the shear forces when the patient's walking. And this has resulted in some pressure areas where the heel has rested on the edge of a wedge, or the midfoot has had a significant localized pressure area where the wedges have slipped and caused sort of a lip at the front. The maximal equinus angle. So the plastic wedges in the top left simply don't go steep enough again. So whilst that's quite a nice system clicking together, wedges can be removed quite easily, and the angle changes as we go. The maximum equinus angle was only about 20 degrees, so it doesn't really bring us into a steep enough angle of equinus. The wedges, obviously, with the flattened top section, which we can see in the other 2 to support the heel and perhaps provide a little bit more comfort from that point of view, simply are the wrong shape to do the job. And what seems to happen is when you remove a wedge to progress the patient forward at any moment in time, what happens is the foot and ankle gets lower to the floor, but the angle does not change. So say if we're modifying a boot system every 2 weeks to progress the patient, we're not actually progressing the patient in a satisfactory manner. We're not changing the angle very much at all at the ankle and changing the tension or the length of the Achilles. We're just keeping it in a very similar angle, but lowering the patient's center of gravity a little towards the floor, or the center of the ankle joint a little closer to the floor. So they were the majority of the problems that we'd encountered, and we did trial a lot of those before introducing the Vacaped boot. And finally, the last issue, which we haven't looked at directly, and I think there's now starting to be a little bit of research in this area, is the fact that at any moment in time with a wedge system, the patient is still in an immobilized position within a fixed angle walker. Obviously, they can take it off to do the physiotherapy rehabilitation, but it's still a very fixed system for the majority of the day. One of the other possible benefits of the Vacoped boot being that it can be dynamized to allow a safe range of motion, which I'll show you in a moment on our protocol from Aintree. It does look like there's early studies showing that there's increased glutamate within the tendons as the healing in a dynamically positioned boot, or a boot that allows dynamization. However, as of yet, I'm not aware of any research that shows improved patient outcomes or strength, 6 to 12 months down the line, perhaps. So that's an area that needs a little bit more attention, but I think, again, would be another benefit of this system. And finally, we therefore, following the trial and introduction of the Vacoped boot, produced a protocol that actually was reduced to 10 weeks. So the benefit of using the Vacoped boot for us at Aintree was that we managed to rehabilitate these patients 2 weeks sooner, allowing them back to full weight bearing, and therefore possibly back to work a little sooner. The diagram there basically shows that we still kept them with 2 weeks non-weight bearing in a maximal equinus cast for reasons that were largely based on logistics of our service, making sure patients didn't do anything silly in those early stages, like take the boot off and think perhaps that the injury wasn't as serious as it was. Whether the extra equinus that's producible from the equinus cast is of clinical benefit is difficult to say. So we probably didn't do it for that reason, but we felt that it was in our patients' best interest to immobilize them kind of safely until they could be reviewed in my clinic, at which point they went into a Vacoped boot, which was pretty typically around 2 weeks. They'd be partial weight bearing with the boot locked at 30 degrees of equinus. And then at 2 weeks following that, it would be dynamized or open to allow 15 degrees of movement. Because at this stage, they're still in a significant equinus position with a rocker sole on the boot, they'd be using elbow crutches and encouraged just a partial weight bear. However, at the next stage, when the boot is open to allow a plantar grade position, so now 0 to 30 degrees of plantar flexion, we were able then to allow them to begin to weight bear as tolerated and change the sole of the boot to a flat one. So at this point, it becomes a lot safer. The leg lengths are now more equal and they're able to walk a little further. Physiotherapy alongside this was left largely to the autonomy of the physio service, although I did provide guidance at the point that I was unable to see a lot of these patients myself in the clinic. I would then typically see them back in the clinic at 10 to 12 weeks. At which point, if they progressed well and their outcomes were looking good, satisfaction was good, there was no significant complications noted, and they had good strength in the calf returning, then they would be able to wean from the boot at that point. And that's the end of my talk today. Thank you very much for listening. And obviously, if there are any questions, I'm happy to field them now.
Thanks, Phil. I am seeing if there's any questions. We don't have any right now. Can you comment on timing of seeing these patients? Do you have any opinion on when it's appropriate to treat these non-operatively, whether it's 24 hours after an injury versus a week after the injury?
Yeah, I think in a typical case where it's perhaps a patient in the mid 40s or 50s, a typical weekend warrior who has a significant event on a sporting pitch perhaps, and therefore attends accident and emergency department quite soon afterwards, then obviously our conservative and functional rehab protocol works particularly well for that type of patient. Again, we applied the 2 week rule so long as they had attended the clinic within 2 weeks, irrespective of what they tried to do with the leg, with the foot and ankle in that time, we would still class them as an acute rupture. And so our service evaluation audit results would include all of that type of patient. Personally, I would be much more keen and probably more able to provide a good prognosis for the patient if they were attending within, say, 3 or 4 days with very little trial of ambulation on the leg. Perhaps that would give me a lot more confidence. personally speaking. And again, it's not for worry of a re-rupture rate particularly, but just because of the possible healing, the possible implications on the healing tendon with regular attempts to ambulate and perhaps stretch the weakened tissue out further.
Right. So you have a professional athlete. What's your preference for treatment?
Well, it's the same. There's some fantastic results, particularly from the UK. I'm not sure about in the US, but
Right.
there's plenty of work from Anne-Marie Hutchinson's group in Swansea at the Morriston Hospital, and their SMART protocol rehabilitated some professional rugby union players back to a very high level of performance. And obviously, these people are a bit like your American football guys, very heavy, very demanding on the leg. And again, there's studies now from Kent in the UK which show similar results with some higher functioning people as well.
Right. But I guess my question is, so what would push you to offer operative versus non-operative for a professional athlete? Because here in the US, we tend to still see elite athletes wanting to have surgery. And quite honestly, most of us
Yeah.
will do surgery on the athletic patient population.
Yeah. I think if surgery can be undertaken within a matter of days, then there's going to be no implication to the actual length of the sort of the rehabilitation and the time of the protocol that's employed after that. In the UK, if there's a delay, particularly within the NHS service, if there's a delay of 1 to 2 weeks for surgery on the initial injury, then you're already behind the ball, because the person who's undergoing the functional rehab will be kind of 2 weeks down the line. We typically don't change the protocol for the two sets of patients, so they'll both go through sort of the 10-week protocol, either from the date of injury or the date of surgery. So actually a tendon that was operated on would be, in the early stages anyway, would be kind of 2 weeks, up to 2 weeks behind. But yeah, no, as you say, if the patient's preference and their experience from their cohort of friends and teammates is massively skewed towards surgery, then we would certainly take that into account. That's not obviously typical of our patient population, I have to say.
Lengthening of the repair or non-operative treatment is a very real issue and has ended a number of careers, especially in the pro athletes. How do you think we can manage that ideally?
I think it's difficult. I think that again, there is some research that in a number and quite a number of months after a repaired tendon, that there's still some lengthening occurring later down the line. So it's not just a phenomenon that's related to the early healing of the tendon. I think it is something that's happening a little more sort of in the medium term as well. And I sort of alluded to the fact that although we might get good apposition of the tendon ends, not all of that tendon is necessarily healthy, and also we lose that spiral architecture. And I'm not sure that there's necessarily going to be a way to reproduce that. I'm not aware of any research that shows that spiral arrangement of the tendon fibers returns at any point with loading. I don't think many of the patients would be happy for you to sort of take samples or try some invasive sort of techniques afterwards. So I think it's difficult. I think the musculotendinous, like the gastrocnemius muscle, can adjust its sarcomeres in length and therefore reduce and improve the length tension relationship a little bit. So if what we see in the physio department often is that patients are particularly weak when they're trying to contract the muscle in a range. So if they try to do a heel rise from a flat floor surface with the foot in a neutral position, they're weaker than if they do it off the edge of a step where they've preloaded the tendon and stretched it, because the length tension relationship is better in that position. So that's typically what we would see in the rehab, and would give us another idea that it's definitely a sort of a lengthening problem that we're seeing. But I think the outcomes with the introduction in the boot, as measured by both functional measures like heel endurance tests, heel rise strength tests, calf girth, and the ATRS score, which I presume is used throughout the world. It's certainly the most common one that we use in the UK. 10-point score to measure the function of the Achilles and the patient's beliefs about the healing Achilles. It does show that there's probably an improvement of about 10 points introducing a Vacaped versus a boot with wedges on these conservatively managed patients.
Got you. What are your thoughts even for over lengthening? Some of the techniques that are coming into the US are trying to lock the proximal stump to the calcaneus, thereby taking some of the tension off the repair and getting you some kind of protection, not only to the repair, but fixation of the proximal stump to the calcaneus. What are your thoughts
Oh,
on
right.
that?
Yeah, yeah. I'm not, well, that in particular is not something I've come across. Most of the surgical options for these acute ruptures was obviously a simple repair process, and obviously for the chronic ones it would be augmented, most likely with an FHL transfer. Yeah, so no, honestly, I don't think I could comment on that really.
Yeah, it's an interesting concept. It's allowing some of our athletes to get back to the field sooner. That doesn't necessarily mean that their performance is better, but they're certainly suiting up faster, right? It's not
Yeah,
9 to 11 months. We're seeing some come back as early as 6 months into
right.
playing pro
Right.
sports. Again, their performance isn't where it should be at that
No,
early.
no, 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 no.
But it's interesting because you wonder if that technique is allowing these guys to come back sooner.
Yeah, yeah, and again, that's obviously not the other outcome that we don't often measure is just that return to work or return to sport, which again is quite a valid one to be looking to improve, as well as reducing the chronic re-rupture rates and the lengthening. We also need to to really appreciate how quickly we're bringing about quality of life again.
Right. Well, and I think that's an important part because I think a lot of the research focuses on return to play or return to sport, but that's not the equivalent of function.
No,
So,
no.
so I think it's a more meaningful discussion to look at function. But this is great. This was fantastic. Any other last thoughts?
No, no, no. It's been a pleasure to be able to speak again on this subject. And no, no. It's if anybody has any follow up questions or wants any of our protocols or any other advice about that, they're welcome to contact me.
Perfect. In that case, we will wrap up this session. Thanks so much, Phil.